So KPMG have kindly supported the forum as headline sponsor for the last 2 years, and I'm now pleased to introduce Mark Britnell as our next presenter. Mark is chairman and partner of global health practice at KPMG. He was also one of the youngest chief executives in the NHS, and he's worked in over 40 countries with hundreds of organisations to transform care. So Mark's going to introduce us today to something to teach, something to learn. Mark.
Thank you very much. Good morning, ladies and gentlemen. And just as Ara Darzi leaves the room, I think just one word. In my 24 years' worth of experience in healthcare, I had the privilege of working with Ara in a small little place called Central Middlesex Hospital back in 1994, when we were basically trying to separate emergency and elective flows to give patients higher quality care, more reliability and better experience. And we designed this ambulatory care and diagnostic centre, and I think that the word for me that starts before even the discussion on innovation is courage. And I remember speaking to Ara, as he then was before he became a Lord, and said, was he prepared to take on some of his surgical and medical colleagues? And the answer was yes. Now, if you ever do get the chance to see a small part of northwest London, I appreciate 50% of the audience or so is not from the United Kingdom. It's a wonderful example of how a hospital that had no real future has transformed itself through separating emergency and elective care flows to develop a dedicated emergency centre and a dedicated ambulatory care centre. And in a sense, I'd like to start with that because the purpose of my conversation with you today is to talk about everyone that has something to teach and everyone has something to learn, but also behind that a much bigger issue that I see now in my global travels, that I think health systems, especially in the developed but also in the developing world, have a very straightforward choice to make over the next decade. And that choice is whether they choose to simply transact their way out of trouble or whether they seek boldly, with some courage and considerable skill, whether they seek to transform their health systems. Now, let me just explain very briefly what I mean by transact and transform. Transact, do things better. Transform, do better things. And over the last 4 years, since I moved away from my position as Director General in the NHS, I've come to realise that there are indeed more similarities than differences in terms of our healthcare systems. Now, Ara mentioned that he had the privilege of presenting in Davos 2 years ago. For those of you that don't know KPMG, we operate across 156 countries. We've been going as an organisation for about 120 years. We also played our part in Davos. Now, I'm not going to seek to read all of this lengthy quotation from you, but it came after the conference in Davos at the World Economic Forum 2 years ago. The first part of the paragraph talks about the usual stuff, that demand is outstripping our ability to supply for a variety of reasons which are very well known and understood. But it's the second part of the paragraph that I've committed and dedicated my last 4 years to thinking about. And I'll read it out. It starts just here. The magnitude of health financing challenges suggests that incremental solutions may not be enough. However, a shared vision of new models for health systems does not yet exist. Now, Ara's pointed in his last presentation to the numerous examples of innovation, which by themselves are spectacular, but they don't add up to a tin of beans. The real issue is, how do we change systems? And what we decided to do recently, just at the end of October last year, is not as usual with highfalutin conferences where we get lots of policy people together. I know that the vast majority in the audience today are clinical and managerial practitioners, but we got together 40 to 45 chief executives, senior clinicians and senior executives from 22 countries across 6 continents to test the hypothesis that we all have something to teach and something to learn, and also to inquire forensically whether we are stuck in transactional mode or whether we are beginning to think about transformation, partly stimulated by the global economic recession. Now, I'm not going to read out these names. They're not that important today. But what I would say is they came from both emerging high-growth markets and traditional, more mature economies. So, for example, from China, we had the chief executive. He happens to be a surgeon as well. From the largest teaching hospital in China, the Peking People's University Hospital. From Brazil, we had the president and chairman of the largest academic health science network in South America. And you can see that we have a number of other people, including, I have to shout him out because I've just bumped into him, Axel from Germany, that runs also a big healthcare organisation, along with people like Lord Nigel Crisp, who some of you will know, and also Sir Bruce Keogh, who's the medical director of the National Health Service. So, people that know what they're talking about, people that have dedicated their lives to improving patient care and the health systems in which they work. Now, I've started to develop a hypothesis over the last 4 years that I want to share with you now, but also over the last 4 years, I've been doing a bit of research myself. Now, last year, KPMG asked 3,000 chief executives from about 21 different industries. So they range from information, communications and entertainment, all the way through energy and natural resources. They also included health and also life science organisations. And this piece of research was really designed to try and understand people's appetite, those people that lead large organisations, their appetite for truly transformational change. And I have to say, the results are a tad disappointing. So 3,000 chief execs from all different walks of life across all different industries globally, the most important thing for them, 43% of them, was basically to think about operational cost improvement and cost efficiencies. 1 in 2 people, that was their primary focus. As you can see here, less than 1 in 4 people were thinking or being preoccupied about deep-seated strategic change. So with this in mind, I decided to drill down. And that same survey revealed, I'm afraid, that most healthcare leaders focus more on the urgent issues of today than on the important issues of tomorrow. Now, if you, like me, think that our existing health systems, from wherever you are sustainable with a bit of tinkering, please raise your hands now. There's one person at the front. I'll just repeat the question to make sure that they got the question right the first time. But this is the paradox. And I bet you recognise this paradox because it happens in a ward, it happens in an operating theatre, it happens in a department, it happens in the GP surgery. Basically, when you ask people whether their health systems are sustainable, the answer they give is no. When you ask those same people whether their organisational plans are sustainable, they often give the answer yes. They can't all be right. It just can't be true. And that's why, in a sense, change is very important. And that's why conferences such as this, 2 wonderful organisations in IHI and the BMJ, are seeking to build a coalition of the willing, a social movement, if you like, as Helen Bevan would say, to think about new possibilities that create a momentum for change. And the conference I had in Rome and the work that we now do globally seeks to reach a new consensus. And it seeks to lift people beyond today with their focus on operational efficiency and take them to a different place 5 or 7 or 10 years down the track. In my 24 years' experience of working in a health system, of managing a teaching hospital, a big region, a country, and now working globally, both in public and private sector organisations, we need to spend more time thinking about the future state that we want to create, as opposed to blaming each other for not being perfect in the execution of day-to-day responsibilities. For the Americans in the audience, last year we conducted some pretty significant research with Harvard and an opinion poll company called Harris. For those of you that live in America, you'll know obviously Harris, we all know Harvard. And we decided, if you like, to play this little trick, this game, this emerging hypothesis on the top 200 health system leaders in the United States of America. For the hospitals, called health systems, for the health plans, called insurance companies, and for pharma as well. And we asked them lots of different questions. It's a 70-page report, but I'll cut to the chase. We asked them, do you think that your own plans in your health insurer, your health provider, or your life science or pharma company are sustainable? And you can see here that the majority thought their plans were somewhat sustainable. When we asked them whether the industry in which they worked will be sustainable, you can see that they expected moderate or major change. So effectively, they thought it was somebody else's problem. Now, without being terribly psychological or philosophical about this matter, that strikes me as somebody who works perhaps 6 or 7 times a year in the United States to be at the root cause and solution behind Obamacare, trying to build a new big tent, a new consensus on the fact that everyone has to change to make a system sustainable, to provide better equity, better efficiency, and better effectiveness. And so with our clever people from Rome, we played the same trick. What do you think happened? They didn't know we were playing this game. In our pre-conference survey, we asked them many similar questions, and the conclusions, as you can see here, that 75% of the participants in Rome thought their organisational strategies were somewhat sustainable, but when we asked them about whether their industries in which they worked and lived, their countries, whether their systems were sustainable, you can see that 95% said they weren't. 30% expected moderate change, and a whopping 65% called for and thought there should be substantial change. If everyone thinks that way, why doesn't it happen? It's because people can't see beyond their own organisational boundaries. And for an organisation, you can read ward, you can read department, you can read operating theatre, you can read GP surgery or community hospital. Now, when we asked these people what they were doing, what was the primary focus of their energy as they come to work and think about work outside working hours, you can see that nearly every single waking moment they're thinking about operational, transactional efficiency. Now, I'm not saying for one moment that's not laudable or correct. I'm merely suggesting it's not sufficient. And you can see here, without me reading through every single line, that basically the focus is on nearly 9 out of 10 cost reduction. Perhaps pleasingly for this audience and this conference, the words of Lean and Six Sigma and improvements in terms of methodologies is now becoming mainstream and commonplace. More focus on specialisation, more investment in health information technology, and also, pleasingly in my opinion, 3/4 starting to think about workforce reform. Less than half expecting more money to save their situation. But it becomes a little bit more sophisticated and complex than straightforward linear change. When you ask a little further about what sorts of income they will receive for their activities, you can see that people are starting to think about quality, about value, and about risk. And just over 1 in 10 thought things would stay the same. Now, quality, risk, and value, as you know, are relatively new concepts. We know quite a bit about quality. We don't put it into practice in a systematic fashion. We know quite a bit about risk, but we don't put it through industrial quantities. We also know a little bit about value. But of course, when you speak now to the new insurers, and I'll say a little bit more about that in a moment, The concept of moving away from paying for volume to paying for value is difficult but absolutely necessary. And in my travels in the 44 countries that I've been to on 130-something occasions, and I flew in this morning from Dubai at 7 o'clock, everyone is talking about integration. It's the most fashionable, overused, well-used word in the healthcare global lexicon. And you can see here that our Rome delegates, 90% of them thought that integration would improve outcomes, and 75% believed they would improve or reduce costs. Now, I could play another game, but I won't. I could ask you whether you think you're working in an integrated system. And you might put your hands up because you're working with great partnership with your local primary care or secondary care or community or mental health provider. But of course, as we all know, structural integration and the world's best examples of this, I'm afraid to say, are in the NHS, which confuses structural reorganisation with integration from the patient's point of view. You can see that if people believe this, and they believe that their industries or their countries don't have sustainable business models, but they think that their organisational models are okay, can you see the absolute paradox? If I'm being a little bit more hard-nosed, can you see a blatantly, glaringly obvious contradiction? And that's why health systems don't change. Sometimes because of politicians, sometimes because of managers, sometimes because of the public, sometimes because of professionals. But more often than not, it's the inability to comprehend and articulate in a visionary way a future state which is sustainable. And the only way you can do that is by respecting the fact that everyone has something to teach and everyone has something to learn. Now, moving on from this, if you do get the chance to read this report, and that's the small subliminal plug just being paraded now, this is the report which we actually produced with the 45 people that came to Rome. And it looks at 5 very important trends. And it's worth a quick flick through. The trends. We are noticing the rise of the activist payer. I'll say a bit more about this later on. Secondly, and I think pleasingly, we are starting to see hospitals not be bound by their 4 walls and actively start to think about transforming themselves into health systems. Thirdly, I know it's axiomatic to us, but increasingly people are seeing patients as partners, not in that soporific come-by-our sense, but in that sort of, I think, business-like sense that understands that if patients become partners, they create more value. If they do not become partners, if they are not treated as equals in a partnership, they can easily destroy value. The 4th conclusion from the Rome work was that high-growth markets, I refuse to call China a developing economy when it's the 2nd largest economy on the planet, that high-growth systems do offer perspectives for us to think about how we innovate in more mature economies. And then 5thly, this issue about innovative integration and authentic partnership. Now, let me just say a few words about each of these. I'm not going to read through all of them, but 3 things struck me in the Rome conference and also as I've been travelling the world. The first one is, if an insurer or a government funder is not thinking about value, value being the clinical outcome divided by the costs of securing that outcome, how can it possibly move from volume to value over 3, 5 or 7 years? It's simply impossible. Now, forgive me if you're not familiar with that great programme Doctor Who, but one of my oldest, and I have to confess, one of my worst jokes is as follows. Why didn't the Daleks rule the world? It was the first step that killed them. If you are not a purchaser, if you are not an insurer that's thinking about moving from volume to value, what hope have you got of making your system sustainable? Secondly, If you don't deeply know the 1%, the 3%, the 5% of your population that drives 30%, 50% or 60% of your costs, what hope do you have in providing better care, more equitable care and more efficient care? And therefore, if you do not segment and stratify your population to get much closer to them to understand what they need, how can you ever change provider behaviour or clinical patterns of care? This is an example which some of you from the Netherlands will know. It's in the north part of Netherlands, not that far away from here, if you think about it. DFZ. Now, Ruth spoke to you today. Ara mentioned some of the work that London's done in stroke care. Here's a health insurer that doesn't own any of the supply chain, doesn't own the hospitals or the GP premises, and look what they're seeking to do and have started to do over just 18 months. Now, it's quite small. It's actually larger than I thought. But basically, wherever you see the number 5, you will then in the future see the number 1 or 2. Centralising specialist care. Centralising oncology. Making sure your newborn and maternity services are fit for purpose. Creating new hyper-efficient elective care centres and completely transforming the way that we look at chronic and elderly care. We all know the theory. This insurer, who happens to be one of our clients, is led by a woman called Diana Morrison. She shows more courage in facing the press and the politicians down to work with patients that have designed these services, in spite of the system, not because of it. She shows courage to innovate and partner in an authentic fashion. I've no doubt that she will complete most of these changes, not all of them, but most of them. And I think what's important for you to realise, as I know you do, and especially if you think about the English situation, with the medium-term economic forecast being rather bleak, if we haven't started already, it's possibly already too late. Now, I never believe that. I'm an optimist by birth. But these things normally take, even with a fair wind and inspired leadership, about 3 years to implement. On the provider side, the picture is much more mixed. And for those systems like the English system, which is fairly hegemonized, I think what this shows you, this work that we've been doing across the world, is that it's okay to have different models. So you can see here that many hospitals now are still, by the way, making fairly decent margins. Now, some are choosing to use that profitability, that surplus, if you like, to transform care, to mend the roof while the sun's shining. And others are sitting there defending their fortifications. But others are starting to think about, do we continue just to do things better, or do we start doing better things? And what's pleasing for me, and a lot of this comes from the East, not exclusively, is that people now are starting to think about different forms of operating. Now, of course, there are some global players. I mentioned them here: Ramsay in Australia, Fortis in India, CCOM in Japan, and Netcare in South Africa. I mean, just a quick word about those sorts of organisations. They're having to standardise across literally tens of countries. And so there is a lot that we can learn from our own health systems about what's right to standardise and to reduce discretionary effort, or dare I say it, clinical variation. For others, of course, the quest to finish off, to start lean, to think about continuous quality improvement, to think about workforce change and care system redesign. And I know that Gary's speaking, I think, today at some point, Gary Kaplan. Some brilliant examples in the US, Intermountain, Virginia Mason, Buurtzorg in the Netherlands, an integrated health and social care provider, and closer to home, David Dalton in Salford. And then you've got some very interesting initiatives, and certainly something which I've got a personal interest in, looking at organisations now that are starting to vertically integrate. And then finally, of course, I know that you've been speaking to Dev Shetty yesterday, and you can see that some of the Indian, but also some of the Finnish providers thinking about becoming more streamlined. Now, the point I want to make about this is everyone knows that hospitals can't stay the same, but then everyone thinks that truism applies to all hospitals equally, when actually what we need is greater differentiation. And that requires imagination and innovation. And the leaders of these organisations have found deliberately with their clinical staff and hopefully their patients a different route to sustainability, higher quality care at the same or lower costs. Now, I know that most people have read Clayton Christensen. I have to say it was a revelation to me because I spent 17 years managing and working in and leading hospitals, and it was a cathartic moment when I read the Innovator's Prescription because it confirmed what I'd felt for a long time. That hospitals, as you know, or 20th century healthcare or 21st century healthcare now, unfortunately, is an amalgam of 19th century general practice and 20th century acute medicine. Apart from that, there's nothing wrong with 21st century models of care. And of course, where you have that conflation, where you have that confusion, where you have that collusion, you destroy value, you destroy quality, and you increase costs. Now, therefore, this proposition needs to change. I haven't got time today to run through these 10 characteristics. They're not rocket science. We can do this if we choose to do it. Kaiser, I've got a great deal of respect for. Sometimes overused as an example, but I know from the work that I've done, whether it's in Germany or the Netherlands or Mexico or Korea or Australia or anywhere else that you care to think about, that most systems, whether they're fragmented, for profit, have principles of social solidarity, are driving towards trying to answer this conundrum through the redesign of this healthcare chain. What I do when I go and meet ministers in various countries, and I'll give you an example. Is there anyone here from Canada? There's a gentleman there. Are you from Toronto? Okay. Right, so it's your minister, Deb Matthews. When we saw Deb, we said, do you know, Minister, how much money you're spending on the 1% of what you call high-end users? Or some people in the health service dare to pejoratively call them frequent flyers, as if they want to fly into hospital 17 times a year. But we asked the question, by the way, played this game across all sorts of countries, including China. How much does it cost for one of those 1%ers? And of course, most systems can't answer that question. Do you know what the answer is? It's roughly, in any given country, about $200,000 US. If you think about that, it would be cheaper for that individual to have their own personal care butler living at home than to take on the vagaries of our uncoordinated and integrated care. So, I think all health systems, for purposes of social inequality as well as cost and quality, need to concentrate on these numbers. And if I ask one thing of you over the next 3 or 4 days, when you fly back, think about, try and find out what those statistics mean for your country. And then you will quickly realise that you need something which looks like this. Now, of course, Kaiser have spent decades integrating their practice between payer and provider, although there's a separation, of course, for legal purposes, but also primary and secondary care and community care. And of course now, in terms of the digital age, moving from monochrome to full, vibrant colour. And this is really what we need to start thinking about. And thanks to my colleague, Professor Nigel Edwards, who I think spoke yesterday, and he, in large part, is the author of this report. This is his diagram. This is a simple pictorial assessment about where we see the health sector, but particularly providers at the moment in terms of the current position as is, to where they need to move. And the vast majority of effort, we contend, has to go into integrated care. Now, patients as partners, shock, revelation. However, you all know, because you are committed to this movement of clinical change, using scientific methodologies, that it's only 10 years ago that people came to understand that usually higher quality care results in less expensive care. My personal belief, it will take us another 10 years to realise that basically if patients aren't treated as partners and don't act as partners, then we will destroy or compromise more value than we create. What struck me in Rome with a lot of alpha male and female chief executives was the growing realisation that this just wasn't a nice thing to do, although they genuinely and wholeheartedly believed in it. They understood it was also business and mission critical. Now, I don't think yet we found the science to lead organisations to systematically embed this. Of course, Don Berwick spoke to you about safety, and we do know what does and doesn't work. I'm not going to read all of these out. These techniques here: shared decision-making, amplified patient voice, informed care, internet coaching, tools, pathways, records, decision aids, social networks, and technology, patients like me. This is all very important. My suggestion, from what I've seen, where value and, more importantly, heartache rests, is in chronic care and end-of-life care. The 1%, the 3%, and the 5%. That's where I would start. And there's a guy called Professor Bastian Bloom, who is a neurologist who came to speak to us. If I can make a second request, go onto the web today and look at Parkinson.net. This is a neurologist that quite clearly says that the movement he's in charge of, or he's supporting, is the movement is to move from being a god to a guide in healthcare. And basically, he's demonstrated it through his own neurological practice in the Netherlands. He has put the patient at the centre of all of the design. He has sought to understand the patient as a human being. Now, I don't know whether this is a truism or an apocryphal story, but do you know on average how many hours of care an average citizen will have in a developed country? Anyone care to guess? Who said that? The answer is 5 hours of care a year. Do you know how many hours there are in a year? 8,700. Isn't it a funny old industry? Isn't it a funny old business that will try and make those 5 hours work even more efficiently and effectively? We need to do that. But isn't it a strange old business or industry that doesn't think about the remaining 8,695 hours of care? People don't live to be admitted into hospital. They live their lives to be supported in wellness and well-being and happiness. And therefore I think what Bas Bloom has done by creating this network that revolves around the patient pulls and draws in professionals, you can see has a great effect. Now, I haven't got time today to show you a video that Bas allowed me to show. But if you go on to Parkinson.net, you will see some of the work that he's doing, understanding patients as human beings in their environment, not for the 7 or 8 minutes, every 4 times a year that they present in front of him. A 50% reduction in hip fractures, a 20 million euro saving. When I was Director General in the Department of Health, I felt proud to lead this whole system demonstrator. I know the evidence base is being challenged, but basically look at these results. This could be a global innovation because we know the Chinese are looking at it through a combination of a rising tide of non-communicable diseases and aging. We know that developed, mature, industrialised countries are looking at it. But if you see here, I'm going to tell you a story about the chairman of Tesco in a moment. If you know Tesco, it's a pretty big supermarket chain. Look at this. In the pilot, the whole system demonstrator, which is the largest randomised control trial of telehealth and telecare in the world, produced results that suggested that mortality was reduced by 45%, that visits to the ER department or the A&E department reduced by 15%, 20% reduction in emergency admissions, a 14% reduction in bed days, and an 8% reduction in prices. Now, I understand that there's been a subsequent piece of evaluation that suggests that the cost benefits may not be that great. I have to tell you, when we launched this, 2006, 2008, 2009, they were in the days of plenty. We weren't going for cost savings. I feel pretty confident that the application of this work could have profound consequences for morbidity and also for cost. And the story about the chairman of Tesco, the former chairman of Tesco, I should add, he just stepped down. I remember talking to him about this work, and I said, David, his name is Sir David Reed. I hope he doesn't mind me mentioning this story. And I said, David, if you saw results like this from your largest randomised control trial globally in Tesco, I said, what would you do about it? Well, he said, I wouldn't be having this conversation with you. I'd get onto it. I'd find out whether the customer liked it, loved it, and wanted to use it. That's what I think we should do. We had the privilege, and this is where it gets a tad more political. We had the privilege of a guy called Tim Harford. Now, some of you will know Tim Harford because he speaks on Radio 4, but he's also published this book called Adapt, Why Success Always Starts with Failure. I'm going to take this one nice and slow because it's a global truism. Today's highly complex challenges do not lend themselves to an early or mid 20th century industrial model of management. The world is too unpredictable and complex for linear management models. Progress will be secured through experimentation and innovation, and improvisation will lead to sustainable change as long as frontline clinicians and patients are given the space, protection, tools and technology to allow experimentation to occur. Politicians have done remarkable things in most countries I've been in. Whether you're the health minister in China that is seeking to provide care insurance for 1.4 billion people in less than a decade, or whether you were Bevan who created our wonderful National Health Service in 1948, whether you happen to be the new Prime Minister or President of Mexico that's seeking to extend social health insurance even further for the 125 million people that live in Mexico, politicians can lead change. Politicians cannot, on a day-to-day basis, manage health services. And therefore the leaders in those health systems which you're part of and many of you are leaders in, have to have the strength to create an umbrella that allows people to experiment and, yes, on occasions, indeed fail. I'm going to say something now which is gently provocative, and I think Robert Francis has done a magnificent piece of work understanding what went wrong in Mid-Staffordshire. But those wrongs were committed. They began in 2006. How many industries do you know would wait 9 years for 290 recommendations to put that hospital in our health system right? If you were any other business, do you think you'd be in business if you didn't make any changes for 3 years, 3 months or 3 weeks? We need to move more quickly. And these countries, some of them, in their own small way, are moving more quickly. Now, I'm not one of these people that says, isn't it wonderful that there's so much innovation in India or China that the West has to swallow it lock, stock and barrel? As you well know, the systems in India and China, their primary care systems, are very poorly developed. Millions of people do not have access to the care that they deserve. But people inside those countries see that as an opportunity to be entrepreneurial about meeting need. And what I do know, and what I have seen, is that there are 3 words, I think, that nicely summarise not only the people that came from the so-called East, or South America and South Africa, or Africa, but buzz, speed and leapfrog. And what I've seen in my travels are these 3 things being deployed at industrial scale. Technology, they're not afraid of it. Smart operational processes, they control them. And public-private partnerships, They've moved beyond the dogma of whether that's good or bad. It's just a question of what works. One of the pieces of work we're doing at the moment with a number of our clients in Africa, in India, and also other parts of the developing world, is we're currently doing a piece of work that is looking at all of the essential ingredients for low-cost delivery, but affordable care, which improves equity and access. And I think we've got a conference very shortly, Nigel Edwards and others in Africa in July, and I hope to, if we are invited back next year, share the results of this work, which I think show great promise and application, dare I say it, to the West as well. Nearly finished. I feel a little awkward telling you something you know. This has to be the greatest statement of motherhood and apple pie you've probably heard this morning, this week, this year. But what was very clear from the people that were in Rome, what's very clear from the thousands of organisations that I've worked with and met over the last 4 years, is that basically people need vision if they are not to perish. And I know it sounds simple, and I know it sounds easy, but that often is the missing ingredient behind sustainable change. And targets, of course, for those countries that have targets, they are not an end. They should never be elevated to an end. They are simply, at best, a mean. I'm not going to read through all these 10, but there are 2 things I want to point out in a second about these characteristics. The first one is, do you see on that list the words structural reorganisation? Do you see on this list the words profit or money? Do you see on this list the words committee meetings? What you see is deeply embedded inside all human beings that care. Enduring values, a shared purpose, consistent and stable leadership, 7 years, 10 years, 15 years plus, deep engagement with clinical staff, strong focus on the front line, set culture, and then hold people to account. I am a partner in a firm called KPMG, which if you did know it, you would think is an accountancy firm. It does lots of things. It's a partnership. We're all professionals. But I can assure you that if, you probably don't know this, but last year KPMG was voted as the second best organisation, employer on the planet for looking after its workforce. I have to tell you, just as a little aside, and I'm sure you won't tell anybody else, on my 9-box matrix that I get reviewed on 3 times a year, I am held to account although we're a partnership. We hold each other to account. What I've noticed in the health system is the organisations that have predictably high control over their clinical process have a very clear vision, stable, empathetic management, which does the tough things well. People say staff development and appraisal is the soft side of healthcare. It's the hard side of healthcare. It's the necessary side of healthcare. And it's the part of healthcare that we don't do enough. And you can see here, which I know has been mentioned, I believe, yesterday, this issue that all of these people, like great people are, have a curiosity about wanting to be better, a restlessness, an impatience, a dissatisfaction about the current state of affairs. And I remember a man who did a lot for safety in the English NHS, Sir Liam Donaldson, a former chief medical officer of England, doing some work with clinical teams before it was fashionable to understand why some clinical teams performed more highly than others. I can't remember all of the work, but I remember when he presented it 7 years ago, one of the words that struck me is that the clinical leaders of those clinical teams were naturally gregarious and curious. They were never satisfied. They were always looking out, wanting to compare. Strivers, if I can use that word in this audience. That's a big quote from Francis that basically says leadership's really important and it needs to get its act together in the English NHS. And I just want to say, because I'm here today sponsoring this conference, and I'm very proud to sponsor it with the BMJ and the IHI, because I don't know how many of you know this, but the NHS Leadership Academy is just set out on possibly one of the world's most bold moves to train and develop 25,000 clinical and managerial leaders in the NHS across 3 different levels. I don't know where you would sit in this pyramid. Ward managers, general managers, directors, clinical or otherwise. It's a huge 3-year programme. And I'm proud to tell you that we're helping support that programme. But much more importantly than our partners, but I will talk to you about our partners in a moment, this programme is fundamentally designed to do something on an industrial scale that I haven't seen in my 24 years in healthcare. And that's to place front and centre, to be the start and the end of one thing, care, 2 things, care and compassion. It will be unswervingly revolutionary on the way that you develop, maintain and hold people to account for the values that the NHS believes in, underpinned by the Constitution. Now you can see here, it's a bit of a busy diagram. These people here, these universities award master's degrees. National Voices is the umbrella organisation that has all of the patient charities and groups together. And then you can see here we've got some major corporate partners, BT, BA, Microsoft, that will be talking about how they change with their values and how they change their business. But then you can see here that the global rainbow of expertise and help that will be on tap, on hand, to support this huge transformation that Robert Francis has pointed to. Erasmus University in the Netherlands, the University of Pretoria in South Africa, to give us a different angle and perspective, Harvard School of Public Health, the European Health Management Association, and indeed the IHI. It's a big job. It promises many things, but I believe it's a global first. So finally, we all have something to teach and something to learn. There are more similarities than differences in our global healthcare systems. The future is with us in terms of innovation. It's just unevenly distributed. Most people believe that their own health systems are not sustainable, but believe that their own health plans are okay. This has to change. And as Gandhi said, be the change you want to see. And in my experience, when I work with systems or countries or geographies, I honestly believe that if we focus in the short term on the 1%, the 3% and the 5%, we will begin to transform our health systems from wherever you come. Thank you very much indeed for listening to me, and if there's time, I'll take some questions. Thank you. Is that too long? Okay.
Thanks, Mark. Lots of interesting stuff there. We've got a couple of questions coming through on Twitter. If you've got a question as well you want to make, you can move to one of the stands around the sides and we'll call you in due course. First question, Mark. You said you've travelled to 40 countries around the world many times. Have any of them got it right? And if not, which has got closest?
Every country has got something to teach, and every country has got something to learn. If you look at the Commonwealth Fund report that Ara posted up, it would seem to appear that the Netherlands is the highest performing health system. Of course, the Netherlands spends about 11.7% of its GDP. When I'm at home with my family and children that I don't see very often, we play a little party game where basically it's called Pin the Tail on the Donkey. And basically I take bits from different countries and put them together. I haven't got too much time to go into that today. I think, as Don said, I believe this week, every country has got significant opportunities to improve. I think the Dutch system is interesting, but they do spend more money than many other countries. So without going into a whole list of different facets from different organisations, I genuinely think we've all got something to teach and something to learn, which is why I think conferences like this and the ones that we put on are so vitally important.
And sort of leading on from that, we had Dev Shetty yesterday, we had Dr. Ravindran talking about the Aravind healthcare system. It seems to be that those emerging economies are leading the way. We're quite jealous of how fast they're able to implement change. And what do you think it is about those economies that allows them to do these innovations at such fast pace?
Imagination, need, overwhelming clinical need, and the ability not to seek permission to do something. And I think it's that third one that slows most developed countries down.
So I'm going to take two more questions, Mark. One that we've got in the audience today, a real mix of managers, frontline clinicians, and other people involved in healthcare. And this question from, I think, Colin McClintock from Australia. How do you transform your healthcare system if your government refuses to do so? So if you're a clinical member of staff and you find it very difficult to go against the system, how do you engage with your senior management or policymakers to transform healthcare?
Which state is he from?
I'm not too sure. It's difficult to pick up the names on Twitter these days, but I did get David. So,
okay.
Or sorry, Collins.
Well, I don't know where he is and you can see me later on, but I thought your government was trying to instigate health service reform in Australia. I was there in December for 3 weeks, working in 5 of the states. Now, obviously, there's still a big debate about the level of subsidiarity between the federal government and the state governments. But I'm afraid I'm going to take the Fifth Amendment because I believe that the Australian government and the states that form part of Australia are trying to reform their system. However, to try and answer the question from a local view, if you're feeling frustrated with the system or the hospital in which you're working, I found as a junior manager many years ago in 1991 that a group of clinicians and myself got together. It's so easy to say this now, but you wouldn't believe this, but in 1991 people didn't have the same day services for many of the cancer diagnoses, so breast or urology. And my advice to you, for what it's worth, is go and make a change with some people that want to make a change and get noticed. Because actually, if you stand on the right side of patients and make that change, it's a very foolhardy, stupid administrator that would dare to change it. And by demonstrating some of the principles behind that change, I think people gather strength and confidence. And the second thing I would say is keep coming to conferences like this so you don't get too demotivated.
And our final question comes from Charlotte. And she asks, you talked earlier about the integration of healthcare. And particularly in the NHS, other countries around the world, we tend to be limited by technology. And the question was about how much that integration is limited by technology in healthcare.
I think you can do a lot before you need really nice systems to integrate care. Certainly around protocols and pathways. They don't have to be automated, although it helps. If you look at the most successful systems, by the way, if you go onto our website, there's a publication called The Power of the Crowd, Accelerating Innovation, and we look at 15 different systems from around the world. And basically the bottom line is they all started and were embedded completely from the beginning in clinical process, and they evolved naturally over a period of time. So I wouldn't be completely disheartened or dispirited if you haven't got a great information system. You can use paper or other visuals, as you well know. If you look at walls on wards. But I think over a period of time it does need to be owned and driven by clinicians. And I would hope that whoever you are and wherever you're from, there's something for you to hang your hat on in that respect.
Mark, thank you very much for joining us this afternoon.
Thank you very much indeed.
Thank you.
Thank you.